Hi everyone. So definitely not the way that I planned on giving this lecture or how you planned on listening to it, but we'll try to get by the best we can. I will probably try to figure out how to put a discussion board up on the blackboard so that you can ask questions, talk amongst yourselves as far as topics are concerned, if you have any questions. Also, if that is just something that you don't deal well with, go ahead and email me any questions that you have on. I get online about once a day to look at emails right now. Sometimes I get on a little more often than that, but in general, that's about how often I'm there. So I divided this into two sections since we have had 2 nights scheduled for this lecture on renal. We're not going to spend a lot of time in chapter 65. I feel like this is something that you learned in anatomy and physiology. And so the slides are there for review, but I don't plan on giving a lecture and reteaching anatomy and physiology. If you have questions about it, your book gives excellent explanations. If there's things that you don't understand in the explanation that they give, feel free to contact me. Also, there's great sites online as well that has excellent teaching on these different, on the renal system. So you definitely have resources out there, which is why we're not spending a lot of time discussing it. I basically have divided the lecture into two parts. I sent you a PowerPoint that included all of the slides for both nights. So you pretty much have all your renal in one packet. And so we'll get started now. We know that the organs of the renal and urinary system include the kidneys, the ureters, the urinary bladder, and the urethra. And within the structures of the kidney itself, we have the calyces, which consist of the nephrons and drain into the ureters. And this is just a picture that talks a little more about the anatomy of the nephron. This should help you as you're thinking about your urinary system medications, like your loop diuretics, because obviously it's the loop of Henle that we're talking about with that. And so refer to these pictures and refer to things like that as you're thinking about these different medications and you're learning more about them. This talks a little more about the Bowman's capsule and the juxtaglomerular complex. These are renal tubules. Again, think about these things, and as far as the electrolytes and how the absorption or reabsorption of those electrolytes in these various loops affect the electrolytes in the body of somebody who is receiving these medications or have problems specifically related to this part of the kidney. And finally, here's a picture of the urinary bladder. Obviously, this is a male bladder because we've got a prostate gland around it, and yeah, women, we don't have one of those. So you can see that the ureters actually come out into the bladder on the lower side of the bladder. And I think a lot of people have this idea because of how the pictures are drawn in most anatomy books that the ureters come out at the top and kind of drip down into the bladder, but it actually fills more from the bottom. And that's why as it's expanding, it has that effect to make you feel like you gotta go. I think another thing that people don't realize is there's actually two urinary sphincters. A lot of people think that there's just one sphincter that's keeping the urine in there, but we actually have two urinary sphincters. When the internal sphincter lets go, it's really difficult to hold urine back with the external urinary sphincter. And so that's usually when we start seeing people having accidents and having to run very quickly to the bathroom. Some of the things that we need to think about as far as the kidney and the urinary system and what happens as we age is that as we get older, there's less blood flow to the kidneys, which is one of the reasons why older people tend to have more problems with their kidney function. Also, the glomerular and tubular basement membranes become thicker. And so there's less absorption and reabsorption that's taking place there. Also, the tubule lengths will decrease and the glomerular filtration rate decreases. This really has a strong effect on how the body uses medication or is able to clear medication. Also, there tends to be nocturnal polyuria. We often think about men who have prostate problems as being the people that are getting up having to go to the bathroom all the night. But both sexes start experiencing needing to get up and go to the bathroom during the night and not having a full night's sleep without interruption. Also, we have a higher risk of dehydration, and that again goes back to that decreased glomerular filtration rate and just the general kidney function. When we're assessing the kidney and people with kidney problems, we want to look at demographic information. We also want to look at their socioeconomic status. So, as I've talked to you before, socioeconomic status has a lot to do with how people eat, and how people eat has a lot to do with how their kidneys function. We also want to look at the nutrition history. If people have had a period of time in their history where there was a lack of adequate nutrition, it can affect their kidney function much later in their life. Or we may want to look at and see if there's been a change that's happened in it, because that can affect their kidney function as well. We want to look at their medication history. You already know that there's medications that are what we call nephrotoxic, where it can cause kidney failure if not caught too soon. We want to look at family and genetic risks. Some families have kidney issues that run back generation after generation after generation. And so the family is very aware that these kidney issues happen in their family, and usually have a very good knowledge of how to deal with them. On the other hand, we may see other genetic problems that are associated with kidney disease. We also want to look at what their current health problems are. Is this somebody who's recently started having heart failure and now is being started on medications that affect the kidneys? Like if they're having heart failure, they may be getting started on diuretics. Well, diuretics have a direct effect on the kidneys, and so we may need to monitor their kidney function more closely. When we look at the laboratory assessments for kidney function, we look at things like serum creatinine, BUN. We also look at the BUN to serum creatinine ratio because that is a direct, uh, can directly show us how well the kidney is functioning and whether it's clearing these solutes from the blood like it should. We also want to look at blood osmolality or osmolarity because the kidneys do control that. When we look at a urinalysis, we want to look at the color of the urine. We want to see if the urine has an odor to it. We also want to look to see turbidity. Turbidity means, does it look opaque? Does it, or is it clear? Does it have things floating in it? Those are things that we want to look at initially before we send it down. We will get reports back that will look at the specific gravity, the pH of the urine, whether or not there's glucose in the urine. There really shouldn't be glucose in the urine. Whether there's ketone bodies, which is a way that which is the result of the body breaking down proteins. If there's protein itself in the urine, in some cases, a small amount of protein is not considered abnormal, but in general, we shouldn't have any protein in our urines. But what we do find is, especially like pregnant women, will have a small amount of protein in their urine. Whether there's leukoesterase or nitrites in it, if there's cells, casts, crystals, or bacteria. Cells could be like red blood cells or white blood cells in the urine, which would lead us to think that there may be an infectious process going on or a hemolytic process going on. Casts are usually like, I'm trying to think of how to explain it. It's almost like if you took a impression of something and this came off of whatever it was that it was on. Also crystals, we don't want to see those, but those are associated with certain types of disease states, like gout. And obviously we don't want to see bacteria in the urine because that tells us that there definitely is an infectious process going on. Some of the other tests that we do are a urine for culture and sensitivity. Obviously, if I've seen bacteria in the urine, I'm going to want to do get usually a clean catch urine for culture and sensitivity. A composite urine collection is when we get urine over a period of time. Most commonly, we see 24-hour urines. Creatinine clearance is the best indication of overall kidney function. Urine electrolytes can tell us whether or not the kidneys are hanging on to electrolytes and it's being expelled in the urine, or if it's putting those electrolytes back into the blood like we may want or may not want, depending on what's going on. We have normal urine electrolytes just like we have normal serum electrolytes, and also the urine osmolarity. Besides that, we may have a bedside sonography or bladder scanners. These are often done after we remove a urinary catheter, especially if we suspect that there may be urine retention. We also may do various urine or kidney imaging assessments like a kidney ultrasound. We may do retrograde procedures where we actually follow a dye up from the bladder into the kidneys. We don't usually like to do those kinds of things, but we can. We may do urodynamic studies, and in some cases, especially if they think that there may be cancer, there may do a kidney biopsy. So let's move on to chapter 6, some questions. And I included these because I wanted you to be able to think about some of these topics just a little bit differently. So the first question says, which patient is most likely to experience renal compromise assessed by decreased urine production? A 10-year-old, somebody with a 10-year history of diabetes, mellitus, a white blood cell count of 12,000, a recent history of myocardial infarction, or somebody with a blood pressure of 92/46 for the last 12 hours. So the way we have to think about this is what's going to cause a decreased urine production. And if you've had a problem like a 10-year history of diabetes, this is not something that's suddenly going to change your urine production. It may over a long period of time, but most likely it's not going to be a sudden decrease. The white blood cell count usually doesn't result in decreased urine production. And a recent history of a myocardial infarction, although it might affect your urine production because of the lack of stroke volume that the heart is putting out, that's sort of reading a lot into that answer. But the blood pressure of 92/46 for the last 12 hours definitely would affect urine outcome because the kidneys have the ability to self-regulate the renal blood pressure. And the renal blood flow is what keeps the glomerular filtration rate constant. So if you had a blood pressure of 92/48, your mean arterial pressure would be 62. And the kidney has a difficult time regulating the mean their glomerular filtration rate, or the GFR, when the blood arterial pressure is less than 65. So we want to definitely keep an eye on things like that. In other words, the kidneys aren't getting enough flow. And what we see when somebody is severely ill is often one of the earlier signs that we see is decreased urine output. And we usually will start low dose pressors like dopamine to increase their renal perfusion so that they have adequate urine output. So let's go to question 2. A patient with kidney failure reports dyspnea. The patient's pulse oximeter reading is 95% on room air, but is visibly distressed with a respiratory rate of 32 breaths per minute. What is the priority intervention? So you're kind of reading this one and going, well, this sounds like a lot of respiratory stuff, but we have to worry about this person because they have kidney failure. So A is to notify the respiratory therapist. B is to administer oxygen by nasal cannula. C is to elevate the head of bed to 90 degrees. And D is to administer a respiratory nebulizing treatment. Well, the respiratory therapist isn't going to be able to do much for them any more than you would be. So on this one, the answer is that we're going to do B, administer oxygen by nasal cannula. Patients that have kidney failure are anemic because they cannot produce the hormone erythropoietin. Erythropoietin is the hormone that the body uses to cause the bone marrow to produce new red blood cells. So if your kidneys aren't working adequately, it's not going to produce that hormone, and so therefore the bones won't produce the red blood cells that they need, and they'll end up being anemic. A high oxygen saturation in an anemic patient who's showing signs of respiratory distress, they may still be hypoxemic. In other words, even though their saturations are fine, and we usually would say, oh, no big deal, they don't need any more oxygen. In this case, they don't have enough red blood cells carrying around that oxygen to adequately oxygenate the tissues. Clients who have decreased hemoglobin could have a high percentage of hemoglobin saturated with oxygen, but because they have decreased hemoglobin levels, not enough oxygen is provided. And so administering more oxygen so that their hemoglobin becomes more saturated is especially important for them. A patient with a history of kidney disease is admitted with acute shoulder pain. Which order should the nurse question? Digoxin 0.125 milligrams by mouth daily. Metoprolol 50 milligrams by mouth twice daily. Pan cultures for temperature more than 38.5. That basically, pan means everything. So culture everything for a temperature more than 38.5 Celsius. Ibuprofen 800 milligrams by mouth every 4 hours as needed for pain. Well, what we know is D, that high dose or long-term use of non-steroidal anti-inflammatory drugs or NSAIDs like ibuprofen can seriously reduce kidney function. So somebody with kidney disease typically will not be on an NSAID. So you want to explore their past and current use of over-the-counter drugs or agents, including dietary supplements, vitamins and minerals, herbal agents, laxatives, analgesics, acetaminophen, and especially NSAIDs. So let's move on to chapter 66. So one of the things that we're going to talk about in this chapter includes kidney stones, which this is a picture of somebody with a kidney stone, and the arrow is pointing to that. I'm not sure what's sitting lower, if it's possibly a stone that's in the ureter, but again, not sure what that other little white blob is below that, but you can actually see two small stones up in the kidney region on this x-ray. Actually, my notes say that there's stones in the kidneys, ureters, and the bladder, which I can't see the bladder in this picture, but I'm assuming that nice big blob there is another stone. So we're going to start out talking about cystitis. Cystitis is an inflammatory condition of the bladder, and it usually refers to inflammation from infection of the bladder, although you can get cystitis and not have an infection. Irritants can cause cystitis, and there is something known as interstitial cystitis. The infection can occur in any area of the urinary tract and the kidney, and still be called a UTI. So UTIs could be the bladder, it could be the urethra, it could be ureters, or it could be the kidneys themselves. As far as the etiology and the genetic risk, about 90% of urinary tract infections are caused by E. coli. So if you think about how close the rectum is to the urethra, it explains how that could happen. Candida is another infecting microbe, and it can occur especially when somebody's been on long-term antibiotic therapy. Catheters are the most common factor associated with the onset of UTIs in the care setting. And when we say catheters, we don't just mean catheters that have been in there for a long time. It could be that somebody had an in and out catheter done for some reason. anytime that you go up into the bladder, you potentially may have either irritated the bladder and urethra, or you may have put some type of bacteria up in there and caused an infection. The incidence of UTIs is second only to upper respiratory infections in primary care. It's the most common healthcare associated infection. So there's National Patient Safety Guideline goals to prevent UTIs. And one of the major ones that they have is using catheters only if it's necessary, and using the catheters for the shortest period of time. So basically we have what's called CAUTI, C-A-U-T-I, packages. And basically what these are is guidelines within the hospital of how we treat somebody who has a catheter. And we want to prevent the infection rate. And so we follow these guidelines, including assessing on a daily basis whether this person needs to have a catheter in or not. And it's something that should be discussed with the provider on a daily basis. Does this patient still need a catheter? One of the other things that we do is we want to make sure that unless they have some other reason for it, that we give our patients a liberal fluid intake. It's kind of like if you have enough going in, you're going to flush out whatever might be trying to come up the urethra into the bladder and cause an infection. So the more you drink, the healthier your kidneys and your bladder and your urinary system is. Some of the things that we need to think of too for prevention is with women. They need to be cleaning the perineal area from front to back. It's interesting. It's one of those things that we just kind of assume that everybody knows. But last summer, when I was teaching pediatric clinical, there was a little girl that had been admitted several times for urinary tract infections. And so, of course, they were doing a more extensive workup on her to find out why she kept getting urinary tract infections. During the process of doing discharge teaching, the nurse said something to the effect of course, you taught her to wipe from front to back. And the mother said, no, I didn't do that. I didn't know that you needed to wipe from front to back. So apparently, not only was this woman not wiping herself from the front to the back, but she had not taught her daughters to do that either. And so we can't make assumptions that everybody knows to do something. It's important that we do that teaching as well. Another thing that we can do for both sexes is they can wash the perineal area before and after having intercourse. Also, voiding after intercourse is important as well, because during intercourse, bacteria can be introduced into the urethra. So when we're assessing or noticing things, on our physical assessment, some of the signs and symptoms that we may see is that somebody is going to the bathroom frequently. They have pain, dysuria on voiding, and they may have an urgency. So when they do have to go, they have to go now. They really don't feel like they can hold it. If the person has a catheter, we want to assess the catheter and the fluid, the urine that is being expelled through that catheter. If the patient is going to have a physical examination, we want them to void before that examination. and we want to perform a focused examination of the genitourinary system. When we look at lab assessments, we want to do a clean catch urine specimen. So we want to make sure that we give them instructions about cleaning from the front to the back and letting a little bit of urine go before they catch some. We want them to void just a little bit before, because that's going to flush any bacteria that's just sitting around the opening of the urethra. Usually with that clean catch urine specimen, we'll get a urinalysis and a culture and sensitivity. We also would get a serum white blood count with differential so that we could see if there's signs that they may have an infectious process. Some of the other diagnostic assessments, they may do a pelvic ultrasound or a CT. Usually I haven't seen that done, but occasionally they may do that. They may do a voiding sister urethrophy, which would show whether or not there were any blockages if somebody's having recurrent urinary tract infections. And they may actually do a cystoscopy where they would introduce a small camera up the urethra so that they could look at the lining of the bladder. Some of the interventions, the non-surgical management is drug therapy. And of course, the first thing that we think about with an infection is that we're going to give antibiotics. And the antibiotics that we would give is usually sulfamethoxazole and trimethoprim, and it's usually given as a combination drug. Those drugs, the common names for those are things like Bactrim DS or Septra DS. Sometimes you'll see those abbreviated as TMP -SMX or TMP SMZ. Basically, they're abbreviating both drug names. Important things that we need to know with those is that they need to be taken with a full glass of water, at least 8 ounces. If their stomach becomes upset, the patient can take it with food or milk. And you want to make sure that they know that they need to drink plenty of fluids while they're taking those medications. Because if you don't drink enough, you have a risk of forming kidney stones. Another medication that's used is nitrofurantoin, and that's also known as macrodantin. It doesn't tend to have quite as many it doesn't tend to form the kidney stones like the others. You don't have to, you still want them to drink a lot, because again, drinking a lot helps you to void out and flush out the bacteria, but it's not as dire of a need as far as needing to be done. Again, fluid intake is really important. Some of the comfort measures, we've talked about how there may be spasms of the bladder that causes people to feel like they have dysuria. The spasms may make them feel like they have to go right this second and they can't hold the urine. One of the ways that that can be relieved is through phenazopyridine, also known as pyridium, or azo, I can't remember the last part of it, but azo makes one of these things. And basically what this medication does is it acts as an antispasmodic, and it will cause the person not to get those spasms of the bladder. One of the things that the patients need to know up front on this one is that it will turn the urine a dark orange. And if even a drop of it gets on your clothing, like your underwear, It will cause staining that doesn't come out. So they may want to wear a pad or some other, or definitely not their favorite underwear when they're taking this medication. They can take Tylenol or NSAIDs while on these medications. As far as surgical management, it treats the condition that increases the risk for the recurrent UTIs. So if someone has some kind of blockage or other problem that increases their risk of developing urinary tract infections, they'll want to repair that so that this isn't happening as often. As far as care coordination and transition management, we want to assess the level of the patient's understanding of their condition. Remember, we have the 3 C's. What's my main problem? How do we treat it? So teach them how to take their medications, how to increase their fluids, how to do things that are going to help prevent this from happening again. And what do I do for this? So address the concerns associated with intimacy and the recurrent UTIs, like the fact that they should get up and go to the bathroom. A lot of people sit there and go, but I want to cuddle after I have sex. Well, cuddling is fine, but at some point, don't just fall asleep there. You need to get up and go to the bathroom because that's going to help prevent those that cystitis. Urolithiasis, or kidney stones, are the presence of calculi or stones in the urinary tract. It's most commonly associated with dehydration and a high urine acidity or alkalinity and drugs that contribute to stone formation. Some of the drugs that are associated with stone formation include things like furosemide, Lasix, which is a diuretic, and you wouldn't necessarily put those two together, but it can cause kidney stones to form. Stones may occlude the ureter, and when that happens, it may result in hydronephrosis, and we're going to talk about that a little later with this lecture. Usually, people will note that when they have a stone, they have excruciating pain. And the pain can be so bad that it will actually put them into a state of shock. So we need to look at the etiology and the genetic risk factors for kidney infections. For instance, metabolically, if you're dehydrated, it increases your risk of getting kidney stones. Most of us walk around every day dehydrated to some degree. We really don't drink as much as we should, and in doing that, we set ourselves up for potentially developing kidney stones later on in our lives. Other patients that are associated with getting kidney stones are people who are white, obese, or have diabetes or gout. Gout kidney stones are really, really bad because they're crystals, and we really want to try to help them to avoid getting those kidney stones. Certain vitamin supplementation is also connected with stone formation, specifically calcium and vitamin D supplementation, and excessively high doses of vitamin C actually can cause uremic kidney stones to form. One other association that we've seen is people who drink a lot of carbonated drinks have a higher incidence of kidney stones, and that's because the carbonation Um, the carb the carbonation of the soda is actually will actually combine and make calcium carbonate. Calcium carbonate is chalk, like what you use on the chalkboard. And so if you are drinking a lot of carbonated drinks, you may want to decrease that because it definitely is associated with higher incidence of kidney stones. The incidence, it varies with geographic location, race, and family history. About 12% of adults will have at least one episode of kidney stones in their lives. It seems like lately I see a lot of men getting them, but I know women get them as well because my mother has them. So definitely it's one of those things that you just want to do everything you can to avoid having them. As far as assessing, we want to ask about a history of urologic stones. If you've had them before, your chances are you'll get them again. You want to obtain dietary and supplementation history so you can pick up these things like, oh, I drink 2 liters of Mountain Dew every day. And yes, I had a patient who drank 2 liters of Mountain Dew every day and wondered why they were obese. But anyway, and you want to know if they're taking a lot of supplements. Are they taking a lot of vitamin C? Are they taking a lot of calcium and vitamin D supplementation? Taking supplementation will not in and of itself cause kidney stones, but when you take excessive amounts, that's when we start seeing the kidney stones being developed. The major symptoms is what they call renal colic. Colic is an irritation. If you think about babies who have colic, they're very irritable. And so we say that the renal system, whatever part of it that has the stone in it, has colic. It's irritable. They'll have nausea, vomiting, pallor, diaphoresis, and often those accompany the pain. And the pain isn't necessarily there constantly. It kind of comes and goes. So if you think about colic as well, it's something that comes and goes. When it's bad, it's really, really bad, and the rest of the time it may not be too bad at all. You want to assess their urine output, and you want to obtain a urinalysis, a white blood count. They may do a CT or a KUB. The picture that you saw at the very beginning, that was just a KUB, which is another way of saying an abdominal x-ray. So the biggest thing that we need to do is manage pain. And this is done primarily through non-surgical management with drug therapy. So initially, they're usually given opioids to deal with this excruciating pain that they're in. However, and they may at times start them on NSAIDs after the pain settles down a little bit. But usually they don't want to give NSAIDs because it can decrease the kidney perfusion. They may give antispasmodics like oxybutynin, which is also known as ditropan. And that antispasmodic will make it so that as that stone is going through the bladder, there's less spasms of the bladder and less pain. Lithotripsy is another non-surgical management of kidney stones. And I'll tell you, that is quite the procedure. I went through that with my son about 6 months ago. And I really should have put a video on this. I'll try to find a video about that and post it for you guys to see because it really is an interesting procedure. And it usually is done as an outpatient procedure. They come in the morning, they do the procedure, and then they're sent home once they're fully awake and drinking. And they're encouraged to drink plenty. They still have pain because the stones are usually still in there. They've just been broken up into smaller sizes so that they're easier to pass. And then they're also told, they're given a very, very fine sieve to pee into, so that you can, and then you save all of the stones that are urinated out, and take those stones into your doctor's visit, and they kind of figure out whether there's still some in there or if you're pretty much done with it. Surgical procedures, they may do an MIS procedures or open procedures to remove the stones. Sometimes they put stents in so that the ureter or the urethra is larger, stretches it so that the stone can pass through it. Often those are not successful, and they end up still having to do the lithotripsy. And at times they may need to go in, and it's just so large and so really socked into that area that it's not going to move no matter what's done. And in those cases, they may actually open up the area and remove the stone. So the biggest thing that we need to worry about is preventing infection and preventing obstruction. So some of the ways that we do that is to increase fluids. In the same way as we flush out infectious processes, we can flush out these stones. And so people are told to drink large amounts of fluid so that they can flush these stones on out. However, if they do become obstructed, then they definitely have to go in and remove those stones or break up the stones so that there's no backflow into the kidneys. I'm not sure why they didn't just put all the cancer, urinary tract cancer information all together. I just kind of figured they didn't because they're kind of starting at the bladder and working their way up to the kidneys. But urothelial cancer is a malignant tumors of the urothelium lining of the transitional cells in the kidney, the renal pelvises, the ureters, urinary bladder, and the urethra. And we usually see this as bladder cancer. It's most common in patients over the age of 60. Some of the things that seem to be associated with it is smoking. So if you are smoking, stop it. We already know that it causes lung cancer and COPD. Well, it also affects your urinary system. So stop smoking or don't start in the first place. Make sure that if you work in an environment where there's dry, liquid or gaseous chemicals, that you wear PPE around those chemicals. And if you come in contact with them, that you shower or bathe as soon as your contact is completed. So when we're assessing, we want to ask about active and passive exposure to cigarette smoke, because we can see this in our patients that have never smoked, but they lived in a house where their spouse smoked. You want to ask about hobbies and occupations, because that may show that there's been a chemical exposure. You want to ask about changes in urine habits or the presence of abdominal symptoms. You want to assess the skin color and their nutritional status. Examine their urine for color and clarity or clearness. You want to assess their psychosocial status and their coping mechanisms as well. Diagnostically, they may do a bladder wash specimen, which would mean that they would put a catheter into the bladder and then wash cells from the bladder. Oops, sorry, I accidentally hit a button I wasn't planning on hitting. This picture over here to the side is a bladder biopsy, and you can see that they put up the biopsy mechanism up the urethra, and then they just take a little section of the bladder, and then they're able to just grab hold of it and bring it out so that they can do cytologic studies on it. They may do a cytoscopy with biopsy of the viable bladder tumor, visible bladder tumor. And in this case, they would actually take a scope and put it up into the bladder, look around, and if they actually saw a tumor, then they would actually take a biopsy of the tumor that they saw. They may do cytoureterography, CT scans, ultrascans, or an MRI. MRIs are really good at seeing the changes and the differences between different tissues. As far as interventions, non-surgical, they may use prophylactic immunotherapy with BCG. BCG is Bacillus calumet-guerin, and this is actually what we use in countries where TB is endemic as an immunization against TB. And what it does is it causes the immune system to attack the cancer cells. It's given directly into the bladder as a wash, and it's usually done after they've removed the tumor that's present in the bladder. Basically, they put the fluid in with a catheter, and then the patient is asked to kind of move from side to side so that fluid can coat the whole inside of the bladder. And either they'll clamp off the bladder, or if the physician removes the catheter, they'll ask that patient to not void for the next 2 hours. After 2 hours have gone by, then they'll empty the bladder either by unclamping the catheter or by having the person void. One of the things that the patients need to be taught once they go home is that BCG is not a dead virus or a dead organism. It has been attenuated, which means that it's still alive, but it's weakened. But because it's still alive, it increases the risk of developing TB itself. And so when they void, they need to be careful to not splash that urine around. And so for men, they recommend that they sit rather than to stand for voiding. And that after they're done voiding, they should put bleach into the toilet and have it sit there for a period of time before flushing it. Um, for men, they should not have any sex for 48 hours because they can pass that BCG onto their um, mate. And women should not get pregnant or breastfeed while they're getting BCG treatments. So you might say, well, they're just going to get it one time. No, they get it once a week for 6 weeks. And so they need to make sure that they're protecting their partners during that time period. And so they should, if they do have sex, they need to be using condoms even after that 48-hour period of no sex. Surgery is usually done by removal of the tumor for diagnosis and staging of the disease. And it can be followed by intravesicular chemotherapy, radiotherapy, or immunotherapy. As far as the self-management education, they need to be educated about the drugs and what they need to do when using those medications. They need to have diet and fluid therapy education, and so a dietitian may be involved with doing that. If they've had their bladder removed, which can happen, then they need to know how to use the external pouching systems. And in some cases, they may have a system where they have to catheterize the bladder, and so they need to know how to do that as well. Some of the healthcare resources includes the United Ostomy Association, where they can get them information about groups that would understand what they're going through. So let's talk a little bit about some questions for this chapter. A 22-year-old male reports burning and difficulty with urination. What priority question will the nurse ask? Are you sexually active? Do you have low back pain? How long have you had these symptoms? And have you had a fever in the past 24 hours? So in this case, going back to that whole UTI thing, the answer is A, or are you sexually active? The most common cause of urethritis in men is sexually transmitted infections, or STIs. These include gonorrhea, or nonspecific urethritis that's caused by uroplasma, chlamydia, trichomonas. And other questions can be asked after you assess whether they are sexually active and might have possible STI exposure. Basically, in men, once a boy gets to be about 10 to 12 years of age, his penis is considered long enough to give him protection against most infections that would have occurred when he was younger because of the short distance of the urethra. And so if a male gets a urinary tract infection after the age of 10 or 12, there's an assumption that it could be a sexually transmitted infection unless they show that there is some other reason for the infection happening, like a blockage or some of the other things that we're going to talk about later today. And so they would culture them for these STIs. And the way that they culture them is not through a urinalysis. The way they culture them is to take the culturette like a very small Q-tip on a wire stick instead of a stick, and they put it up the urethra, and that's how they culture those. Just an FYI about those. And then once they know what the causative agent is, then they can treat that infection adequately. Number 2, the nurse is caring for 4 patients. Which patient does the nurse assess to be at greatest risk of developing a kidney stone? A Caucasian male who is obese, African American female with family history of kidney stone, female with history of frequent urinary tract infections, or D, Hispanic Latina female who eats animal protein at every meal. Well, if we think back to our people that are at most risk of developing kidney stones, we would know that A, our Caucasian male who is obese is at higher risk of developing kidney stones. Anyone can form a kidney stone, yet they're more common in males. Caucasians, patients who are dehydrated, those who are overweight, and those who have had kidney infections. Those with a family member with kidney stones and those who've had kidney stones before. Number 3, the nurse has placed an indwelling urinary catheter via sterile technique. The nurse recognizes that it is how long before bacterial colonization begins? 12 hours, 24 hours, 48 hours, or 72 hours. Now, we didn't directly talk about this during lecture, and so I'm just going to go straight and answer that one, and that's 48 hours. Catheters are the most common factors that place patients at risk for UTIs in a hospital setting. Within 48 hours of catheter insertion, bacterial colonization begins. So the goal is to remove the catheter within 48 hours after placement whenever clinically possible. About 50% of patients with indwelling catheters become infected within 1 week of catheter insertion. And that doesn't mean that it's still in, but they may become infected even after it's been removed. So what I want to tell you as we start this chapter is that we're not going to complete this chapter. We are just going to get about halfway through. And I wanted to talk about the things that I'm going to talk about in this chapter because some of them relate to things that we've already talked about. And so rather than leaving and coming back to this, I wanted to be able to make sure that you got an understanding of these other infectious processes. This particular picture is a picture of somebody with a polycystic kidney. The one on the left is the external surface of the kidney, and the one on the right is the internal surface, like if you had cut it open or sliced it open. And we're going to talk about those before we leave with this lecture. But for right now, and I'll refer back to this picture when we get to the section on polycystic kidneys. But right now we're going to talk about pyelonephritis. And if I was to write a textbook, I probably would have talked about polynephritis at the same time as I talked about UTIs because they are related to each other. And pyelonephritis is a bacterial infection in the kidney and the renal pelvises. So in other words, in the upper urinary tract. They can be acute or they can be chronic. And the causative organisms are the same kind of organisms that cause the UTIs that cause cystitis and urethritis. They are more common in women that are ages 20 to 30 years of age. So when we're assessing, we're going to ask our patients if they have recurrent UTIs, if they're diabetic, if they've had kidney stones, because that may often stones are there because of infections. If they have any kind of genital urinary defects that they were born with, if they have reduced immunity, so somebody who is getting cancer treatment, for instance, or somebody who has a problem with their immune system, somebody who has HIV. These would be people that would be more prone towards getting UTIs. Also about their kidney function or anything that might affect their kidney function. The symptoms may be similar between the acute and the chronic presentation. So you may not know right up front whether, unless you ask these questions, whether somebody is having an acute infection, which means it's just suddenly come up, or if it's chronic, something that they've had over and over and over. You want to inspect the flanks, and the flank area is the area just above the waist and to either side of the spine. And then you want to do a psychosocial assessment. Is there confusion, anxiety? Is there some embarrassment? Are they feeling guilty? I don't really think you get a lot of guilt except if they end up having like a chlamydial or gonorrhea, pyelonephritis, but or it could be a young teenager who's developed pyelonephritis because they've had sex for the first time. When we look at the labs, we'll do a urinalysis. We'll probably do a C-reactive protein, EST, a BUN, and a creatinine, and a GFR. Blood cultures and a white blood count. When you start getting kidney involvement, then you have a higher risk of getting what they call urosepsis, which means that we're getting sepsis, or an infection of the blood, because of the infection in the kidney. The infection causes the kidney surface to be more permeable, and that allows the infection to get out into the bloodstream. They may do a KUB or a CT looking for obstructions or other reasons why the infection may be going on, and in some cases they may do a kidney biopsy. So what we see is pain, usually flank pain, but occasionally abdominal pain. Everybody's kidneys sit in the abdominal cavity differently, and so they may tilt slightly to the front, and if they tilt more to the front, you may have more of an abdominal pain. If they tilt more to the back, it's going to be more back pain. If they're just the way they're supposed to be, you'll get more of the flank pain. And that's due to the inflammation and the infection. And something that you always need to be keeping in the back of your head is that anytime that there's an infection like this and inflammation going on inside of the kidney, that inflammation causes damage to the tissues. And because of that inflammation, that increases the risk of chronic kidney disease, because this tissue can be destroyed by that inflammatory process. So when we're looking at implementation or interventions, we want to manage pain. And so when we look at non-surgical ways to manage pain, pain medications, same ones that we would use for UTIs. Antibiotics. If we stop the infection, we're going to stop the pain and the inflammation that's involved. And If this patient has developed this pyelonephritis because of a urinary catheter, and they still need to have that urinary catheter in, we need to make sure that we remove the previous one. Usually we culture it as well. And then we also replace it before we start the antibiotic therapy. Because if we leave that catheter in it, it's going to continue to reinfect the bladder and can keep that infectious process going. As far as surgical management, basically we're looking at correcting structural problems or obstruction problems like pylorothotomy. In other words, getting those kidney stones out of there. We may need to do a nephrotomy or a ureteral diversion. And basically we want to look at doing everything possible to prevent chronic kidney disease. As far as care coordination and transition management, often people don't end up in the hospital for a community-acquired kidney infection, because usually those kidney infections are a result of a UTI that just has traveled on up into the kidneys. So we start treating the kidney infection, and they go home on antibiotics and pain medications. If it's something that was a result of a catheter, then yeah, they're going to be in the hospital with that. But in most cases, we're going to give them the education that they need for home care management. Things like making sure that they take all of their antibiotic, that just because they start feeling better, they shouldn't stop taking it. They may need antispasmodics, and so how to take those and the information that they need to know, when to call their doctor. Self-management education has to do with how to prevent these things from happening again, and then what their healthcare resources are and how to contact those. And then when your patient is reflecting back, we want to hear that their pain is under control, they're knowledgeable about their disease, the treatment, and interventions necessary to prevent or reduce any chronic kidney disease progression. Glomerulonephritis, again, anything that ends with itis means that there's an inflammatory process involved. Is in a primary, it's divided into primary and secondary. Primary is when it's a condition that involves the kidney itself. Secondary is when the glomerulonephritis is being caused by a condition or a syndrome that is affecting some other part of the body, and it's just part of this overall problem in another part of the body. In addition, we divide it also into acute and chronic. Acute means that it's developed suddenly from an excessive immune response within the kidney tissues. And when it does develop that way, especially if there's an infectious process involved, it usually occurs about 10 days from when the infection was first noted. Chronic glomerulonephritis is also known as chronic nephritic syndrome. And in a couple slides on down, I've actually added a slide that's not in your slide group to help to differentiate between nephritic and nephrosis, because we're going to talk about both of those. And people have a tendency to get these two words that are really similar mixed up. So when we get to that, I'll make a bigger deal about it at that point. So when we're assessing these patients, we want to ask about recent infections, illnesses, whether they've had surgeries, if they've had systemic diseases, or a change in their urinary elimination pattern. We want to inspect their skin for lesions or incisions and assess for signs of edema. We want to compare their blood pressure currently with what their baseline blood pressure normally is. When we look at their laboratory assessment, we're going to look at urinalysis, a 24-hour urine collection, BUN, creatinine, and GFR. Other diagnostic assessments may include a kidney biopsy. So when we look at the symptoms that are associated with acute glomerulonephritis, or AGN, we see generalized edema, and that's because the decreased glomerular filtration allows proteins to escape out, and this increases the edema that's present usually in periorbital areas around the eyes. The face is more prominent, especially in the mornings, and it spreads during the day to involve the lower extremities and abdomen. So if you think about it, when you're laying out flat, your edema sort of goes all the way out all over the body, evenly, more or less. Maybe, if you sleep more on your back, you may have a little more edema to your back. But in general, things kind of spread out pretty evenly. But your head and your face normally are not on the same level as your heart. And so that's why you get more edema around the face in the morning. And then as you're sitting up and doing things and walking around, that edema that's up in your face moves out of your face and starts affecting the lower extremities, the abdomen, and other parts of the body. They also tend to have hypertension, and that's due to increased extracellular fluid, and they get oliguria, so they have less urine output and severely reduced volume. They have hematuria, so there's bleeding in the upper urinary tract, and it results in smoky brown urine that resembles the color of tea or of cola. And they have proteinuria, which means there's increased amounts of protein, and that signifies an increase in the severity of the renal disease. So now instead of keeping protein in the intravascular space, it's now crossing over those tissues in the kidney, and it's coming out in the urine. So as far as interventions, we want to manage the infection. Since most of these are being caused by an infection, we want to manage the infection by giving antibiotics. We may give modifying immunity medications such as corticosteroids. That will decrease the inflammation. They may also use cytotoxic drugs like cyclosporine to decrease the immune responses. But if someone is on either one of these drugs, then they need to be careful around people that have infections. They want to avoid being around people that may have infections because they are at increased risk of developing secondary infections. You want to prevent complications. So some of the complications that are associated with glomerulonephritis include fluid overload. And with that, if you're not voiding out that fluid, it has to go somewhere. You're taking it in. So that's part of why we've got the edema going on. So these patients may be started on diuretics. They may be given sodium and fluid restrictions as well. Their output, and usually when they're on the fluid restriction, they will look at the volume of output plus about 500 to 600 milliliters per day as the total amount of intake that they're allowed. When these patients have oliguria, they tend to have increased potassium and BUN levels, and so their diet needs to have protein and potassium restrictions. So we have sodium restriction, potassium restriction, protein restriction, and fluid restrictions. With the hypertension, they may be on antihypertensive drugs as well. With chronic glomerulonephritis, it tends to develop over years to decades, and the symptoms may include mild proteinuria, hematuria, hypertension, fatigue, and edema. They don't know exactly why people get chronic glomerulonephritis, but there is some evidence that IgA may be a component that's involved in that problem. So this is the extra slide that I told you that I was adding on. And if you look at this, this is also known as nephritic syndrome. And with nephritic syndrome, we have this inflammation of the glomeruli, which results in oliguria, hypertension, and that cola-colored urine because of the hematuria. There's actually a form of this known as Berger's disease or IgA nephropathy, and it's the most common cause of primary glomerulonephritis. Think about our little guy here with nephrotic syndrome, and with nephrotic syndrome, we have hypoalbuminemia, we have hyperlipidemia, and that results in peripheral edema, massive proteinuria, so we have a lot of protein in the urine, and so think about this when we get to the nephrotic syndrome, because that's one of the next slides that we're coming up to. So back to our nephritic syndrome, or a chronic glomerulonephritis, we're going to ask about other health problems, including recent exposure to infections. We're also going to ask about their urinary elimination patterns. We're going to assess for systemic circulatory overload and uremic syndromes. So in other words, that cola-colored urine. Diagnostic assessments are going to include the 24-hour urine collection, BUN and creatinine, phosphate levels, arterial blood gases, kidney x-rays, or CTs. As far as interventions, we're going to focus on slowing down the progression of the disease to prevent complications. We're going to look at the dietary changes. We're going to look at decreasing fluid intake, the drug therapy, and even with treatment, often these patients require dialysis or transplant as time goes by. So now to that nephrotic syndrome. So think back to our little person a couple slides ago, and what we're going to see with them is a condition of increased glomerular permeability. So in other words, things are passing over the tissues much easier than what they should. That allows larger molecules to pass through the membranes into the urine and to be excreted. So if you remember, that person has proteinuria. So the proteins aren't staying in the bloodstream, they're passing on through and being voided out. The massive loss of protein into the urine results in less protein in the bloodstream, which causes edema formation. So think about how fluids cross tissues, and it wants to be equal on both sides. So if we have more protein on one side and less protein on the other side, we're going to get more fluid rushing over to this other side. And that's going to result in the edema formation and the decreased plasma albumin levels. The most common cause is altered immunity with inflammation. So basically what happens is the body secretes too much protein in the urine, causing decreased protein in the blood, which causes edema to occur. The liver, sensing that albumin levels are low, increases lipoproteins, which causes hyperlipidemia. And in most cases, it's caused by damage to the glomerular vessels. Persons with nephrotic syndrome are at increased risk of clotting due to decreased intravascular volume. So fluid is moving out of the blood flow, out of the veins, out of the arteries, into the tissues. That's why you have edema, because it's moving out into the tissues. They're also at higher risk of infection, and they're also at risk for acute renal failure if they have steroid-resistant nephrotic syndrome. So what we see is our patient is going to have tachycardia. They're going to have edema that begins in the face, pale skin, and they may have fissures or breaks in the skin. They'll have hyperlipidemia, which is abnormally elevated levels of lipids, proteinuria, which this got cut off, but protein in the urine, and they may have vomiting as well. So as far as the management goes, we're going to give supportive care. The diet is going to be low to moderate in protein, sodium restrictions when there's large amounts of edema present. If there's not a large amount of edema, there's no sodium restrictions required. Steroids are the first line of therapy, and the dose is 2 milligrams per kilogram divided into twice-a-day doses. Prednisone is the drug of choice. It's also the least expensive and the safest. Immunosuppressant therapy like cyclophosphamide can be used. Again, it acts on the immune system so that it stops attacking this area that's inflamed. And then because of all this extra fluid that this person has on board, they may be given diuretics. As far as nursing interventions go, aseptic technique during any catheterizations. You want to avoid unnecessary catheterization and early removal of indwelling catheters. You want to prevent nosocomial infections, so make sure you wash your hands before and after contact. You want to wear gloves for care of the urinary system. You want to do routine and thorough perineal care for all your hospitalized patients and avoid incontinent episodes by answering the call light and offering a bedpan at frequent intervals. We will also want to ensure adequate fluid intake. Patients with urinary problems may think drinking fluids will be more uncomfortable, but it dilutes the urine and it makes the bladder less irritable. It flushes out bacteria before they can colonize. We want our patients to avoid caffeine, alcohol, citrus juices, chocolate, and highly spiced foods because those are potential bladder irritants. When we discharged home, we want to have follow-up urine cultures. Recurrent symptoms typically occur 1 to 2 weeks after therapy. We want to encourage adequate fluids even after an infection. Low-dose, long-term antibiotics to prevent relapses or reinfections, and to explain the rationale so that your patients are more likely to follow the plan. When people know why we do things and why it's important for their health, they are much more prone to follow the plan. So I told you that we would talk about polycystic kidney disease. Remember, that was that very first slide for this chapter. And you saw all of those almost like blisters and bubbles on the kidney and inside of the kidney. It's a genetic disorder that results in fluid-filled cysts, and it develops in the nephrons. It's associated with hypertension, abdominal fullness and pain, cyst bleeding and hematuria, kidney stone formation, infections, and systemic disease. It used to be that people didn't know why these things happened. But what we're knowing now is that polycystic kidney disease is usually something that someone's born with, hence why it's genetic. It runs in families. And if you talk, like I used to talk to some of these families of babies that were in the NICU that had a polycystic kidney disease. And they would say, oh yeah, his dad has it, grandpa has it, the great-grandparents, it's like as far back as they can think of, people have had kidney problems because of this polycystic kidney disease. So when we explore the family history, that's what we find, generation after generation with polycystic kidney disease. You want to ask about pain, constipation, urine changes, hypertension, and headaches. They may have dysuria and nocturia, and the diagnostic assessment includes ultrasounds of the kidneys, MRIs, and urinalysis. So how are we going to intervene? Well, first we're going to manage blood pressure, and we're going to manage the high blood pressure with ACE inhibitors. Occasionally they may be on ARDs, and that's because, remember, one of the side effects of ACE inhibitors is a dry cough. And so if this person is not able to tolerate the ACE inhibitors because of the dry cough, they'll change them often to ARBs because the ARBs don't tend to cause the dry cough as much as the ACE inhibitors do, but are protective for the kidney. The families also need to learn how to monitor the blood pressure so that they can see if there's a change. If the person's becoming more hypertensive, they may need to have their dose adjusted. We want to manage pain. These patients become in chronic pain. And because they're in chronic pain, they may be on acetaminophen or opioids. And we try to avoid NSAIDs, and they shouldn't try to take aspirin. Remember, NSAIDs can affect the blood flow to the kidneys. So we want to analyze in these adults what type of over-the-counter pain relief they're using, as well as what type of prescription pain relief they're receiving. Remember with constipation that opioids can cause constipation. So with this chronic pain, they may also have constipation that's related to it. We want to encourage them first to make sure that they have adequate fluid intake, that they're eating foods that are high in fiber, and that they're getting regular exercise. What we find too, in addition to the opioid use, is that as these cysts on the kidney become larger, they put pressure on the bowel, which can also cause constipation. Although they will end up using various forms of medications for their constipation, we really want them to try to avoid that as much as possible, because they can become addicted to their use and not be able to have a bowel movement without them. We want to slow the progression of their chronic kidney disease. Obviously, this is something where genetically and physiologically the kidney is already undergoing damage. But one of the ways that we can slow that progression is by having increased fluid intake, up to 2 liters per day. We want to have them have decreased protein intake. The medication tolvaptan can decrease vasopressin in the bloodstream, which will improve blood flow to the kidneys and slow the kidney volume growth. It can also retain function of the kidney for a longer period of time. So you might ask me why I'm going to go ahead and talk about hydronephrosis. Well, one of the things that happens when there is an obstruction or other abnormality of the ureter is that hydronephrosis can happen. And it's the dilation of the pelvis and calyces of the kidney due to the buildup of urine. It happens when the urine cannot drain out of the kidney to the bladder because of blockage or obstruction. And it can occur in one kidney or in both of them. And it can also occur as hydroureter. It depends on where the obstruction is taking place. And so as you look at these pictures, the one on the far left is normal, and as we move to the right, you can see that we have hydroureter and hydronephrosis happening, and finally a very severe form of it where it's almost like a polycystic kidney. So when we do the assessment, we want to focus on a history of kidney or urologic disorders. One of the things that we might find is that children were known to have frequent urinary tract infections, and no one caught on that they were having a few more infections than what they should have been. They may experience flank or abdominal pains, chills, fever, and malaise. The same kinds of things that we get with kidney infections. So we want to inspect the flanks, palpate the abdomen gently, and we may want to use a bladder scanner to see if the bladder is holding as much urine as it ought to be. Diagnostic tests include a urinalysis, BUN and creatinine, an ultrasound, or a CT of the kidneys. As far as interventions go, urologically, if a kidney stone is causing a problem and making it so that the person has hydronephrosis, then we may want to urologically get those kidney stones out, which could include having a stent placed or having lithotripsy done. One of the other causes of hydronephrosis is actually when a child is born with their I forget which part it is, but basically what happens is there are flaps, for lack of a better phrase at this point, that allows the urine to flow the direction it's supposed to flow. Well, they're born with those flaps backwards. So instead of allowing the urine to flow out, it gets stuck. And so some kids are actually born with hydronephrosis, and in that case, they actually have to go in and correct those so that they allow the urine to flow out correctly. Your book talked about radiologic procedures and talked about nephrostomy being done. Really, it's a surgical procedure that's done under with radiologic guidance. That would be the best way to describe it, because you're using either a fluoroscopy or ultrasound to actually guide the nephrostomy tubes or placement of the nephrostomy tubes. And this allows that fluid that's in the kidneys to be removed, and it's drained either outside of the body into a nephrostomy bag, so they have an ostomy on the outside, or they can use that to have it drain directly into the bladder, so then they still void normally. Obviously, you would be concerned about infection with these, and it would be important to make sure that families were taught how to do the nephrostomy care correctly to avoid infections. So that's all I have for you right now, and I wish you all a great evening, and I hope to talk with you online or by email in the near future. Good night.